the team asked if I would just do a bit of an overview about attachment and reactive attachment disorder and what's the difference. So just to start in a very basic way, to state the obvious, babies communicate. So this baby might be saying something like, "Not very intriguing nose, Dad." But not all communications are attachment behaviours. So attachment behaviours are really characterised by being urgent and noisy, and really the aim is to get attention and hopefully to seek comfort. So this baby's obviously very distressed, and actually the communication here could be a horrible tummy ache, do something now, or something like that. And really, we are instinctively, as adults, we're instinctively programmed to respond urgently to this. So a real whistle-stop tour of attachment, and many of you will know lots about this already, but it's a fundamental human instinct. It works across all species, according to John Bowlby, and I don't think anyone's disagreed with that. When a young infant is stressed, he or she seeks proximity and comfort. Virtually always noisy, will involve movement in humans where the child can move, so reaching out to be picked up, or actually toddling towards a caregiver, making a lot of noise to get the caregiver to move towards the child. And the way John Bowlby described, and I love this, is the idea that we're actually evolved to be hunter-gatherers, and if we're herd animals. And if you imagine what happens to a young infant who becomes separated from the herd, going to get eaten. So actually, this instinct to keep close to the herd is really crucial for safety, and also for calibrating stress responses and making sure children just don't get too distressed. Attachment behaviours, so crying, reaching out, moving to seek proximity, are present from birth, but selective attachment is present from about 6, 7, 8, 9 months, where infants will begin to prefer special adults, mum, dad, gran, older sibling, people that they've actually grown up with. And the fundamental point is that attachment patterns are a measure of the relationship. They're not a measure of the child. So it's quite possible to have a different attachment relationship with mum than you do with dad, for example. And the measurement of the attachment patterns classically and most reliably has been done by using the strange situation procedure around the age of 12 to 18 months, and probably because children are so mobile, they express their attachment behaviours in motion at that age, so you can see it. And I'm not going to go into the details of that, but it's been described as a drama in 8 episodes. So it's a series of separations and reunions where there's points where a stranger enters and there's points where the infant is on his or her own. Very stressful, quite stressful for an infant. And in the general population, and this is remarkably stable across the world, even in socially fragmented shanty towns in South Africa, for example. About 60 to 70% of mother-infant dyads, pairs, would be described as securely attached, and the other 30 to 40% is insecure. So I just wanted to reflect briefly on what does that mean if 30 to 40% of dyads are insecure. So I thought I'll look up the definition of normal. So this is the Oxford English Dictionary definition of normal: conforming to a standard, usual, typical, or expected. For example, it's quite normal for puppies to bolt their food, but not all puppies bolt their food. So using that definition, I would argue that insecure attachment is within the bounds of normal. Because let's face it, if you had a class of 100 students, probably 30 to 40% of them would have had an insecure attachment relationship pattern if they'd had a strange situation conducted when they were 12 to 18 months with one of their parents, but they've grown up fairly typically. So just to summarize that, is insecure attachment a disorder? Well, it's present in 30 to 40% of dyads in the population. It's a feature of, when I say dyads, for those of you who are not used to that psychological speak, It's basically, I just mean a pair, a mother-infant pair, or a father-infant pair. Insecure attachment is a feature of a relationship, not of an individual. So I've used the term not pervasive. I'll explain that in a moment. Most infants who have an insecure attachment pattern on a strange situation experience a pretty typical development. And actually, some have argued that insecure attachment may actually be an advantage in some circumstances, certainly for the whole herd. And I once saw Pat Crittenden, an attachment researcher, speak, and she said, you know, you might want someone who is avoidant in your group. So avoidant attachment describes a situation where in the strange situation, even in those stressful situations, you don't see much obvious distress from the infant. And you know, you could imagine that that could have its advantages in certain circumstances. So no, I would say that insecure attachment is not a disorder. It doesn't fit any of what, you know, the criteria of what I would see as a disorder. So I'm going to now move on to talk a bit about reactive attachment disorder, which is a bit of a different thing. And a few months ago, well, no, actually, it's a few years ago now, actually, a group of us in Glasgow, we were asked to get together as a group of clinicians and discuss the NICE guidelines on attachment, which I think, Barry, were you and Pascal both involved in that? I have a very long, a colleague that I've worked with for many years called Suzanne McRae. She's a very experienced clinical nurse specialist who works with looked after and accommodated children. And a clinician I would really trust, but Suzanne doesn't like diagnoses. She doesn't think in terms of diagnoses. But she said, I think failure to seek comfort is the most important symptom to look for in an abused and neglected child at any age. And so when Suzanne says something like that, I listen because she really knows what she's talking about. And since then, I've come to agree with her more and more. I want to give you a clinical example. And all of us here who are clinicians, we probably all have a child in our mind who you kind of worry about most, that comes back into your mind even years after you've worked with them. This little boy, I first saw him at the age of 9. He had been adopted since the age of 4.5, and his adoptive parents described him as withdrawn and contemptuous of them since about a month after placement. So for that first month and in the whole pre-adoptive period, there was a honeymoon period. They described him as resisting the relationship with them. He would never go for comfort. They couldn't think of a single example of this boy ever going to them for comfort or to help with problem solving, homework, anything like that. Terribly sad statement, but they said his default setting is misery. They warned me that he would frequently dissociate, and actually I could see that. He came into the room and sat on his dad's knee, but you could see there's a kind of blankness. He had an additional rare phenomenon that can go along with this. He had a very severe problem with gorging, and yet he was of short stature. And David Skews described this, it's very rare. And it was interesting in school because initially the school saw him as fine because he was articulate and compliant in the classroom. But then they began to notice that in the playground, he could be extremely aggressive if he was trying to steal food. I work generally, clinically, I work with abused and neglected children, and sometimes their histories sadly tend to merge a little bit, but this boy's history really was extreme even for that group in the terms of the degree of abuse and neglect that he'd experienced. At the age of 20 months, he'd been found wandering the streets in his pajamas. But he wasn't placed in care until he was 4.5, and that was a very traumatic experience for him because basically what happened was one of his older brothers was being sought by the police, and they literally broke the door down, and then they found this child kind of rocking and clearly very neglected, and he was taken into care at that point. We've actually written this up as a case report with the boy and the parents' permission, but we did think that he fulfilled diagnostic criteria for what's called reactive attachment disorder. And there are only two diagnoses, psychiatric diagnoses in the classification systems that are thought to be specifically associated with abuse and neglect. So people often think of post-traumatic stress disorder as being associated with abuse and neglect, and it can be. But then PTSD can also be associated with having been in a car accident, for example. Whereas reactive attachment disorder and one other disorder, which I'm not going to talk about today, are thought to be only to occur if a child has experienced very extremely abnormal early care. And the symptoms are failure to seek and accept comfort, emotional withdrawal, limited positive affect, unexplained episodes of irritability, sadness, or fearfulness that don't really link to anything that the parents can see, and in the context of abuse and neglect. And I mentioned pervasiveness before, because if you're a child and adolescent psychiatrist, you're taught on day one that you don't call something a diagnosis unless the problems are evident in more than one situation. And also, you wouldn't call something a disorder unless it causes you functional problems. In other words, it gets in the way of your daily life. So there's been very little research on the prevalence of reactive attachment disorder, but we did a population study a few years ago looking for reactive attachment disorder and also the other disorder that I mentioned, I'm not going to go into, that's associated with abuse and neglect. And at that, back then, both of those disorders were called reactive attachment disorder. So if you're confused, everyone is. But we found essentially what other people had found, which is that in the general population, reactive attachment disorder is really rare. So we screened 1,700 6 and 7-year-old primary school children, and we only found one little boy who had a very clear diagnosis of reactive attachment disorder that wasn't mixed in with the other attachment disorder. And actually, he was the one child that we actually referred to child protection. So clinicians and scientists who work in this field think that the reason that reactive attachment disorder is probably very rare in the general population is because it usually melts away in infancy if the child is placed in a nurturing placement. And that's actually been shown by a really fantastic randomized controlled trial called the Bucharest Early Intervention Project, which showed that when children were moved from big Romanian institutions into family foster care, symptoms of reactive attachment disorder largely disappeared very quickly. But what we've found, we're probably one of the few groups that have done research on this disorder in older children. And a colleague of mine, Kate Moran, did a study of attachment disorders in young offenders attending specialist child and adolescent mental health services. And what she found is that it wasn't rare in that population. About 20% of those young people had fulfilled diagnostic criteria for either reactive attachment disorder or a mixed picture with reactive attachment disorder and the other maltreatment specific disorder. And Kate and I have just done a bigger study of young offenders in a big prison in Scotland, about 114 young people, and we found a prevalence of 17% of reactive attachment disorder or mixed reactive attachment disorder and the other attachment disorder. And I've been asked, what does it look like in older children? And actually, it's exactly what you would expect. So if you think about failure to seek and accept comfort in a teenager, you know, a young person who tells you often using 4 letter words, where to go, particularly when you try to talk about relationships. So just to kind of pull this together a bit, the way that I've conceptualized how insecure attachment, how attachment patterns might relate to reactive attachment disorder, if that at the bottom there is the general population, then about 40% of us would have had an insecure attachment pattern if we'd had a strange situation procedure done with our mum at 12 to 18 months. A lot more would have to happen in order for you to then develop reactive attachment disorder. And my hunch is that it's probably got to be neglect and abuse, very extreme abnormal care. But then not all children who've been by all means, by no means do all children who've been abused and neglected develop this. So one of the things I'm quite interested in is whether there are particular type of neurodevelopmental profiles, particularly that maybe make some children a bit more at risk, vulnerable to this. But this is probably should be even smaller. It's a tiny proportion of children with insecure attachment who would go on to have reactive attachment disorder. So I said I would hardly mention disinhibited social engagement disorder because disinhibited social engagement disorder, which is the other so-called attachment disorder, isn't actually thought to be anything to do really with attachment. But I mention it briefly because it often co-occurs. But back to reactive attachment disorder, why is failure to seek comfort so important? Well, I think there's emerging evidence that if it's untreated, there might be really quite terrible long-term consequences. So, for example, but this is still circumstantial evidence. Nobody's been able to do a massive enough study to be certain of this, but we know that 30 to 40% of abused and neglected children in the care system will self-harm. We know that violent offenders almost universally have a history of abuse and neglect, and Kate and I have shown that really quite a surprisingly high proportion have reactive attachment disorder. I have had a tiny handful of clinical, clinical engagements with young people, older young people who've got persistent reactive attachment disorder. And because it's so rare, and also because there's been some skepticism about whether it ever exists in older children, we've written this up, and you've got the link earlier. But what we found was that 2 out of the 3 had experienced family breakdown. You know, the burden was horrendous for those families and for the young people, and yet it's so easy to treat. And we're hoping that this study might eventually be able to demonstrate that. But Mary Dozier has talked about the use of gentle challenge, so encouraging foster carers, adoptive parents, or birth parents who kind of getting themselves back on track to just be a tiny little bit intrusive. So in other words, like giving the child what the child needs rather than what they're asking for, because they're usually not asking for very much, but it needs to be gentle. And that seems to work very well. But if there are complex problems, then clinically, I would be recommending specific treatments like video interaction guidance or video interaction positive parenting or child parent psychotherapy. And very briefly about assessment. So we've developed a suite of assessment tools, including a semi-structured interview called the RADA, and I've put the reference in there because we've also done a review of all of the existing tools. But for under 5s, the gold standard would be the disturbances of attachment interview, although we've got a screening questionnaire that can be used at that from the age of 1, really. There's also an observational tool called the RENAB that's been quite well validated. It's quite a hefty rating process that needs to be gone through for that. For children over the age of 5, the RADA, and we've developed a waiting room observation. In fact, I see Jen Young Southwards here, and she was very instrumental in helping us validate that. For the future, I've been very interested in the fact that I actually think that we as adults are almost primed not to notice reactive attachment disorder. Because if you think back to what happens in a typical attachment scenario, you know, the infant makes noise and fuss and you know, and that's what we're primed to risk. That's what gets our instinctive caregiving behavior going. And so if a child doesn't signal, then it doesn't get that caregiving instinct going. So we're kind of primed not to notice it. And so I've been working with a computing scientist called Alessandro Vencarelli, just to see if we can actually find artificial intelligence ways of doing this. And this is what he does. He develops a field called social signal processing. And interestingly, he looked at some of our videos with that kind of, you know, through that filter, and actually noticed that there's low leg movements in children with reactive attachment disorder in a kind of stressful clinic scenario, which makes kind of obvious sense if there's a kind of lack of signaling, there's a lack of movement. But of course, as psychologists and psychiatrists, we tend to think from the neck up. So I think this is something for the future, but I do think it's a particular problem with reactive attachment disorder that we're kind of primed not to spot it. So that's really all I want to say, and I'd be really interested to know what people's views are.